are welcome to email me or Kate Carmody at the end, and we will share a recording link with you. While our presenter is speaking, we'll have the lines muted to reduce unnecessary noise, but we will unmute at the end of the presentation. I would like to encourage you, though, to enter your questions into the chat box throughout the presentation because we can start conversation as soon as he's done and have a queue of questions waiting. I'll turn it over to our physician consultant, Dr. Lisa Letourneau, to introduce today's speaker. Lisa?
Great. Thanks, Kelly, and thanks, everybody, for joining us. Lisa Letourneau. I have the privilege of working with Kelly and the American Board of Internal Medicine Foundation on the Choosing Wisely initiative. We're really pleased today to welcome Dr. Tim Hannon. Dr. Hannon is a board-certified anesthesiologist with over 20 years' experience leading large-scale transformation initiatives to improve safety, quality, and efficiency of care across the country. He holds his medical degree from Indiana University, as well as having an MBA from Butler University and a graduate certificate in patient safety from the University of Illinois, Chicago. He also brings incredible experience as a retired Navy captain who served 30 years in active duty, including 2 tours as a flight surgeon. He currently serves as CEO of Healthcare Forward, an organization that's committed to advancing high-value care and has done a tremendous amount of work in this area. So, Tim, we're very pleased to have you, and turn it to you.
Oh, thank you very much, Dr. Letourneau. Thank you, Kelly, Kate, for the opportunity. Again, Tim Hannon and I'm very honored to have the opportunity to share with you a little bit about at least our approach to scalable, sustainable, we think, choosing wisely and high-value care initiatives. So again, thank you for the opportunity. I certainly, as a disclosure, as Dr. Letourneau mentioned, I'm CEO of Healthcare Forward, but really just a practicing physician and anesthesiologist that just has a real passion for these sorts of things. I don't want to spend a lot of time on the why before the how. I would assume most everybody on the line is already fully enthused about choosing wisely, about reducing low-value care, et cetera. I only have a couple of slides more to sort of, I think, prime the environment or talk about priming the environment for what we're all trying to do, which, again, is making sure patients get no more and no less care than they need. Hopefully you all saw or heard of an article that was published last week in JAMA. This is an update of an article I think originally published in 2012, trying to quantify waste in the U.S. health system, and it did pick up some popular press, including the New York Times, I think the Wall Street Journal as well. What the article said, and I think we all are aware of, is somewhere around 25% of the U.S. healthcare system costs are really associated with waste. And of course, there's administrative waste, there's the burden of monitoring, there's pricing failures, et cetera. What we're really focusing on, of course, is the clinical side, which is, again, overuse, overtreatment, et cetera. So again, I only mention this because I think it's good for all of us when there is not just journal publications, but also popular press focusing on the opportunity to reduce costs and increase affordability and accessibility for healthcare through more efficient practices and cutting out waste. The other thing I was very excited to see, and I think many of you have also seen, last month the Institute of Healthcare Improvement started their next big initiative, and this initiative they're actually calling the $1 trillion checkbook. And once again, it's focusing on waste in the U.S. healthcare system. Their numbers are closer to 30% in terms of what they estimate again, the non-value added activities are, and have created what they're actually calling a moonshot to reduce 50% of non-value added activities by 2025. Whether that'll happen or not certainly is in question, but when you have the Institute of Healthcare Improvement throwing their focus, their resources behind it, I think it's encouraging for all of us that are working to, again, choose wisely and reduce unnecessary services as well. So again, those are two things that I think are important for us to be aware of. They're also good things to communicate to your executive teams and your hospital boards to really enunciate at a higher level what we're all working on day to day to day. and this is from both of those articles, you've seen this before, you know, the waste in the U.S. healthcare system, it's that wedge between a sustainable growth or sustainable GDP percentage and what we're actually seeing approaching, you know, 18 to 19% of the GDP. A big component, as I mentioned, and so our focus primarily is clinical overtreatment, overuse, et cetera. So I think I'm required by federal statute when you talk about value in healthcare to show you the formula that you've all seen many times before, the healthcare value equation. Actually giving a talk to IU Med School later this evening, my alma mater, about high value care and medical education. So we'll talk about this a little bit. You're familiar with it. Of course, value is not just cost, but the outcomes over the cost. The problem is, even with this awareness, we're not really making a dent either in terms of better outcomes or lower costs. Not that there isn't opportunities, but they do seem to be somewhat marginal. To me, sort of the light came on when I saw Scott Flanders from the University of Michigan sort of modify this equation and put a in front of it. And I think that variable makes all the difference in the world because the issue isn't so much that we need to continue to focus on outcomes and cost. We do, but the biggest really driver of value in healthcare is eliminating non-value added activities. Those things are not appropriate based upon guidelines, evidence-based guidelines, best practices, et cetera, and that's really where we need to focus. So I would say what we're trying to do through the Choosing Wisely network and through high value care programs, et cetera, is to drive the appropriateness sort of filter through what we do in healthcare every single day. And as we all know, that A is a big A in terms of appropriateness, quite a bit of opportunity to, again, right-size appropriate use of both medical diagnostics as well as therapeutics as well. And again, good quote here from Peter Drucker, you know, that there's nothing so useful as doing or useless as doing something efficiently, which we shouldn't have done in the first place. So again, my spin on the value equation. So our goal ultimately through the Choosing Wisely network, through the Choosing Wisely guidelines, and through our independent efforts are culling out low value care. And of course, those are things that are unlikely to benefit our patients given cost alternatives. And importantly, patient preferences. Now, when I went to medical school, you know, last century, patient preferences weren't necessarily in the mix as much as they should have been, but that's an important thing to make sure that our patients are not just, it's not just our opinion of what is cost effective and what's valuable, but what's important to our patients. And of course, that changes over time. Don Berwick previously said brilliantly, what we're all focusing on, reducing waste, is by far the largest, most humane, and smartest opportunity. Those two things that I mentioned previously, the article in JAMA as well as the IHI moonshot, I think all align with that as well. So let's get into the you know, what are we going to do? So we're all familiar with the why before the how. Before I really talk about the how, what I want to do is show you just a couple of slides that are important for you to understand sort of the origins of overuse, because I think they then help us build a better system to manage in the long-term overuse. So the first thing that I want to point out is, you know, as the joke goes, what's the most expensive healthcare technology? And people think of robots and they think of cancer drugs and things like that too. It used to be the most expensive healthcare, you know, piece of equipment was a pen. Now it's a mouse. So the physician's mouse or the provider mouse is the single most expensive piece of technology, because what's well quantitated is 80% of all spending decisions are made by physicians. And that's in spite of the fact of shared decision making, consumer reports, et cetera. But we need to understand that physicians still, by and large, drive the vast majority of healthcare decisions. And what that's going to lead me to is to say, if we're going to build a sustainable, scalable system within our organizations to drive out low-value care, it needs to be physician-led and it needs to be physician-owned. And both leadership and ownership are important parts of the sustainability and the scalability of anything that we do. The second thing is, this is kind of a busy slide. I was talking to Kelly and Kate and said I usually have this, you know, sort of 5 bullet point limit on a slide. So I violated it. It's more than that. But it's a consolidation of the literature saying, you know, why do we have overuse in the U.S. healthcare system? I think you're all familiar with these things, but I'm just sort of naming names here. The top three that I list there actually come from a survey done by the AMA, published in 2017 to, I think it was over 2,000 physicians, and asking them, one, do you think there's overuse? Two, what percentage of waste do you think there is in the U.S. healthcare system? And number three, what do you think are the drivers? And so most agreed that there was unnecessary services. Most said maybe 15 to 20% was their guesstimate for waste or unnecessary activities. But the big three reasons that physicians list for overuse are, number one, it's those darn lawyers. Number two, it's those darn patients. And number three, we just can't access tests. And so I think it's important for us to acknowledge and build into our programs to, support high-value care, to choose wisely, that we acknowledge these concerns that physicians have, and to some extent at least mitigate or point to how we can deal with these. So for example, medical legal concerns are typically overestimated by physicians, but acknowledging it is a concern largely through driving the use of evidence-based guidelines, both nationally and locally, we can mitigate or stop much of that, at least potential medical legal risk. And when we look at patient-driven expectations, all the data says that shared decision-making is a very, very effective tool that brings patients to the forefront in patient-centered care. And we find that patients who are informed in a logical and a sort of healthcare, what's the term, literate way, often choose more conservative approaches. So the Choosing Wisely group, to its credit, engaged with the Consumer Reports to push out information to our patients to make sure that they're involved in this as well. So the rest of it, again, you can certainly see care team dynamics. It's not just providers, physicians that drive this. It's bedside nursing, it's PAs, et cetera. Misalignment of incentives. Daniel Wolfson, popped in briefly and talked about, one of the challenges in the United States compared to, say, Canada or Europe is we still have a fee-for-service system. So even if we do things that are maybe not necessary for patients, we are incented in line because we get paid more to do that. Thoughtless ease of testing. It's just awful darn easy to check, CBC to infinity and beyond. And then knowledge gaps, I think, is worthy of talking about, and it's a big focus of what we try to do within our system or systems is really talk to physicians like adults that they are and educate them on the right way to do things. And so when you look at it, I'm a blood guy and worked on blood utilization for years and years in my own system and then a number of other systems. There's only 4 blood products, and we still struggle to make sure physicians choose the right product in the right dose for the right patient. When you look at something like a laboratory panel, if you boot up at your local hospital the lab formulary, there could easily be 1,500 tests on there. So how is any physician going to possibly know the appropriate use of all 1,500 tests, or for that matter, all the things on the imaging formulary as well? So education and support is really what our physicians need to choose wisely and make those right decisions. So with that preamble, let's kind of get down to brass tacks and talk about at least, my view of how do we help physicians choose wisely, how do we scale it, how do we make it sustainable, and how do we get them to own the process per se. So our approach has been, a name is everything, and so what we call the program that we helped establish in the McLaren system up in Michigan, it's a 12-hospital large IDN, is decided to call this a high-value care program. And I think it was important to sort of come up with a name that people, once they understood what it represented, that they could get behind. So high-value care, again, the definition that I pulled from somewhere, simply balances potential benefits of any diagnostic or therapeutic against the potential harms. That's basic Hippocratic oath, but also then incorporates the cost of tests and treatments along with patient preferences. So we call this a high-value care program, and then we put that information out to providers, administrators, as well as patients to understand, again, we're not trying to cut back on anything. We're not trying to call out, unnecessary care. We're actually trying to promote appropriate use of therapies and diagnostics based upon risks, benefits, cost, and importantly, patient preferences as well. The key to this, I believe, and I think I have some evidence at least in one health system, is the governance infrastructure. And as boring as it may sound to talk about governance, remember I said that physicians drive the vast majority of all spending and all medical decisions. We have to have ownership, we have to have leadership by physicians across the system to be able to make this work. And so what we have, and again, this is in the McLaren system, is we have a high value care steering committee, which is chaired by the system chief medical officer, and that's very important to show that leadership. It has a number of key physicians from across the system in different specialties. And that steering committee really is what we call in the military, it's air cover. They don't do the grunt work, but they provide the resources, the support, the direction, the prioritization to be able to support projects at the front line. At each one of the hospitals, there then is a high value care committee. We model this really off of a blood utilization committee. However, the chair typically of these committees at each one of the hospitals, and there's 10 big hospitals across the McLaren system, are chaired by the chief medical officer again. So again, physician leaders both at the system and at the hospital level, and then other key physicians on that, as well as administrators, nurses, allied health, et cetera. So again, we see this dual governance both at the system level and at the site level very important in terms of interoperability and local ownership, remembering that the system really provides that air cover and direction to be able to affect change at the front line within the organization. We then have, and this will make a little bit more sense in a graphic, for any particular proposed practice change, if we're going to change repetitive testing, if we're going to change thrombophilia testing, ASB, et cetera. We then have a task force that is set up of local experts. Many times it's an ad hoc group of bringing in infectious disease specialists or maybe laboratory specialists or imaging specialists to set up a task force. That task force then works through the evidence, comes up with implementable recommendations, and then passes them back through the system of governance, both at the hospital level and as well at the system level. And then a tremendous amount of support in terms of analytics, data gathering, informatics, and communication teams that affect the change as well. So again, as boring as this is, we think one of the keys to success is this physician-led infrastructure, both at the system level as well as at the site level, and then this modular approach using working groups, task forces, and a variety of support assets as well. And again, I think that'll make a little bit more sense when we talk about specific projects. The core of our implementation strategies is heavily evidence-based, and I would challenge you to say, if you look at any paper published anywhere in terms of clinical transformation, and probably many of the people on the line have published that literature, any strategy that we would use is going to come under one of three categories: either an education and communication component, an audit and a feedback component, and then ultimately in this day of the EHR is a hardwiring component as well. So every single practice change that gets vetted and implemented goes through this sort of three-pronged overlapping strategy of education, communication, audit, feedback, and hardwiring. A key component, we believe, to the education communication component is that we set up a dedicated website for the high value care program at McLaren, and this becomes a mechanism to sort of broadcast goings on, what's new in the program, what are upcoming practice changes, when is the next summit, et cetera. So a open and I think effective communication source has been developing a website specifically to the high value care program. One of the key components of this is mobile friendly and that it's open. So we decided not, for example, to put this under the firewall of the hospital where only a physician with a access, for example, to the internal milieu could access it. It's open access and is also mobile friendly as well. This is incredibly important, particularly for our graduate education programs where, generally you're not going to see these young medical students and residents logging onto a computer. They want and need that access in real time. So again, a mobile friendly website is one main component of our communication and education strategies. In terms of audit and feedback, we have a growing list of key performance indicators. Every time that we approve and pass a new practice change, there is a metric associated with it. And so we have a growing number of dashboard items. I know at some point dashboards get so big as to be somewhat unmanageable, but the goal here is to set it and forget it. When we create a metric for a new project, once we get it under control, it becomes more of a monitoring process. So as we grow more practice changes and we grow more metrics, we remain confident that this sort of a process, a dashboard process, will work. And there's a dashboard at the system level, there's a dashboard at the hospital level, which again, the hospital leaders are accountable for, and then that gets pushed down, if necessary, to departments and individual providers as well. So audit and feedback is certainly a big component of what we do. And then the final piece, and I think this was originally the title of the talk, right, is, how do we affect clinical decisions? These day and age, it really has to be hardwiring the EHR. If you look at blood products, I mentioned, we were changing blood utilization back in the old days prior to Cerner and Epic and all these other things. And I think we were fairly effective, or I know we were fairly effective, but that's for different blood products. As I've mentioned, if you look at trying to manage a laboratory formulary, an imaging formulary, a medication formulary, you really have to hardwire it into the system. Otherwise, you're just kind of chasing your tail with education and re-education. So hardwiring the EHR is a very important component of this, and one of my favorite sort of infographics is on the left-hand side here. This comes from the Institute for Safe Medical Practices. I used to fly, off aircraft carriers, so I'm a safety guy at heart, and certainly I was frustrated when I saw in the operating rooms when an error occurred. If we did anything to investigate it, typically the recommendations were, don't do that, change the policy, let's educate. Well, we all know the only way to really fix it in perpetuity is to hardwire those particular safety systems. Well, it's the same in the EHR. So EHRs that basically say, here's a link out to a choosing wisely list is not going to be effective at driving behavior. Even putting a pop-up that says, hey, doc, did you really want to order that is annoying, right? This is part of alert fatigue. Ultimately, we knew from the beginning that we're going to have to hardwire changes. We're going to have to drive through the EHR practice changes to make them sustainable. That's why we went with the governance structure that we do. We understood if we didn't have that ownership buy-in at the site and system level, if we didn't have traceability, trackability, and very aggressive communication and education, that these practice changes and changing physician practice through the EHR through hardwiring simply wouldn't work. So I go back to beginning with the end in mind. The single most effective thing we do is wherever possible, we hardwire the system to stop physician behavior rather than auditing it on the back end, but we put in a very extensive, as I mentioned, governance and communication system to be able to get away with that, for lack of a better term. At the right hand of the screen, I have sort of an important point here. A great article out of the Cleveland Clinic by Gary Prokop looking at the effectiveness of interventions to reduce same-day laboratory testing. So what the Cleveland Clinic saw, and I think it happens in most health systems, is the ER orders a panel of tests, then the patient goes up to the ward, and the hospitalist orders that same panel of tests because they didn't bother to check what was already ordered and what may already be resulted in the system. And so the Cleveland Clinic saw that opportunity and through a variety of odd circumstances implemented changes to limit repeat daily testing. In some hospitals, they did it through pop-up alerts. In other hospitals, they actually hardwired it, where physicians would get an alert that said, you can't order that because it's already been ordered, and oh, by the way, here's the last laboratory test, but if you really, really want it, here's a phone number to do it. So when they looked at the sort of hardwiring, which is showing prior results, making it hard to reorder it without a special call versus a pop-up, they saw it was twice as effective to be able to do that. So again, beginning with the end in mind, what we do whenever possible, we hardwire the process. Now, technically, what we actually do for the most part is we nudge physicians. So for example, if there's something on formulary that shouldn't be ordered, we simply remove it. And that's really the hardwiring In many cases, though, we put the default position where we'd like the physician or the provider to order, but there is a workaround with a little bit of extra work. Well, I didn't know what that was called until I read this book called Nudge. I'd recommend you all read it. Thaler and Sunstein actually won the Nobel Prize in Economics for this particular book. There is now at the University of Pennsylvania, they actually have a nudge unit, which is really looking at how can we engineer nudges into the healthcare system, which I think also plays into what we're all trying to do, which is nudge physician behavior. So nudges it's called choice architecture, nice term, designed to influence behavior, but still doesn't restrict choice. So we put the default as the easy thing to do. You can still do the non-default, but it takes a little bit more work. Examples happen every day. Probably while you're listening to this, boring talk by Tim Hannon, you're ordering something on Amazon. Well, what Amazon does when you order that cook set, they also say, well, people also buy this soap, or they buy this towel, or they buy something else. So every single day we're being nudged by Amazon to say, well, you can also do this. We'll make it easy. You don't have to. But again, they kind of move us in that direction. I think probably the most best example I could illustrate is opt-in versus opt-out for organ donation. So typically in the United States, state by state, we have an opt-in system for organ donation, and we have about 25 or 30% of people on their driver's license who opt in to being organ donors. There are a couple of countries where it is an opt-out system, that by default you are an organ donor, but through a process you can actually opt out of it. And in those particular countries, they see organ donation rates north of 85%. So again, that's a nudge at its heart, is we nudge providers into a preferred mechanism or preferred course of action, but there's always the opportunity with a little bit more work to opt out of it as well. So what are some examples? We did this years ago. We didn't know it was a nudge. Is putting a default for red cell orders, non-bleeding, non-actively bleeding patients, that it's a single order. If you want more, you can do it, but it's a couple of extra clicks. One of the things that UPenn did as an early project is they found that when doctors were searching for drugs, typically what would come up at the top of a pull-down list was the trade name, and the generics were underneath of that, and that led to a lot more trade versus generics. By simply reordering the trade name to come up at the top of the pick list, they dramatically increased generic prescribing. And then I already mentioned what was done at the Cleveland Clinic is really a nudge that says when you try to order a test that's already been resulted, here is the results of the test. That in many cases gets the physician to abandon that order, but there's always the option to pick up the phone and call the laboratory. So nudges is ultimately most of what we're doing in the EHR to hardwire this. Last couple of slides here really just talk about our strategic plan. What we really envision with the high value care program, again, we had a lot of conversations about the name, kind of a half full versus half empty, low value care versus high value care. But we really saw this as a platform. So rather than saying, well, let's have a blood management program, and then let's build a separate lab stewardship program, then let's build a separate imaging stewardship program, and then let's integrate our antimicrobial stewardship program, what we really envisioned was a platform through this governance structure, remember, at the system leadership as well as at the hospital leadership, physician-led, physician-owned, supported by administration. And that's what we've actually seen. The program, in terms of being, boots on the ground, is less than 18 months old, and yet we are actively engaging in blood management projects, which is really a reboot of a previous blood management program that we had helped to establish. We have a fully engaged lab stewardship program. We are now delving into imaging stewardship through the appropriate use criteria project that I'm sure most of you are working on. We have had several pop-up opportunities in antimicrobial stewardship. We are just establishing a critical care task force, and we're now working on the outpatient side with the ACOs, the owned medical group or groups within McLaren, working with a Blue Cross Blue Shield, what's called a resource stewardship initiative. So in the span of less than 18 months, under this really universal umbrella, we are working a variety of overuse, overdiagnosis, overuse problems within healthcare, and I think we see this growing even from this. Just to show you, this comes from the Institute of Healthcare Improvements white paper that I mentioned previously, the $1 trillion checkbook. When they quantitated where that $1 trillion comes from, this is essentially the Pareto or the reverse Pareto chart that they came up with. What I have on this slide may be a little bit hard for you to read, but it'll be in the slide set, is I've asterisked the areas that were actively engaged in the high-value care program that constitute probably 20 to 30% of the projects that the IHI has laid out. So even at this early stage, we believe, and we have some evidence to show, that a single platform using, really just a central committee and site committees can actively manage, analyze, improve, and control a number of different utilization issues across the hospital, all of which are supported by, frankly, the Choosing Wisely list as well. Last thing here is just some sort of demo and talk about a couple of projects that we've done. One of the kickoff projects, remembering that we had already sort of conquered most of the blood utilization issues, was laboratory testing, particularly repetitive lab testing, set it and forget it. We looked at both repeat daily testing, which is often, CMP, BMP, EIEIO, as well as tests that really should be ordered on a specific frequencies, TSHs, lipid panels, et cetera. We found at a baseline a lot of daily ordering, which was really unnecessary and not patient-centric, and a lot of the left hand not knowing what the right hand was doing within the same hospitalization, for example, several TSHs, several hemoglobin A1Cs, et cetera. So we saw this as a great opportunity. One of the things that I had mentioned as part of the infrastructure that we built at the system at the site level is we had to then design, again, very boring and very wonky, but really a practice change process map. So how does a bill become a law? And we went through a lot of work to define if someone says, hey, we should do something about thrombophilia testing. Hey, we should do something about asymptomatic bacteria. How do we vet that? How do we prioritize that? How do we support that in terms of putting together an implementation plan? And how do we approve that both at the local level for each one of the hospitals and at the system level? And then on the back end, how do we execute? And on the back end for execution, we've already talked about, there is always an element of the communication and education plan for that practice change. There is a audit and feedback plan in terms of metrics being pushed out to the individual hospitals. And there is always, wherever possible, a hardwiring process as well. So we developed a process map that we use for all of our practice changes, which also becomes, as I mentioned, sort of a traceability and trackability. So if a physician goes, who the heck came up with this idea, right? You're not the boss of me. What we could easily show and what the hospitals could show and these physician leaders could show, well, it was these people, on this task force, vetted by the steering committee, approved by our local high-value care team, and here's that membership, here's the evidence behind it, this is the rationale, and this is how we're going to support it. So the traceability and trackability, we think, is an important part of this, as boring as that sounds, to really get past most of the objections that physicians have. It's, who came up with this, what was the rationale, and why are we doing that? So again, I think it's another important part of the scalability of the program. So I'll just show you a couple of infographics. I really like the gosh, now I'm blanking on it, the infographics that the surgeons use. I'm sorry, somebody in the chat thread can remind me. I'm sort of embarrassed now, but surgeons came up with these visual abstracts. They came up with visual abstracts as a way to sort of engage people. I'm not going to pick up the entire, journal of surgery, but if you show me kind of, what the basic elements of this study are, I can get the gist of it in sort of a semi-visual way. And if I'm interested, I can actually hit that link and go and read the journal article. So sort of playing on that visual abstract, we've developed a format for infographics that every time there is a practice change, we develop an infographic that is then distributed across the hospital system, which gives the why, what, and how. Why did we do it? What did we do? How are we doing it? And there is always a QR code that links to a landing page on that website that we talked about that then has, who was on the task force, what's the rationale behind it, where's the white paper, where's the evidence, where's the choosing wisely list, et cetera. So as an example, this was one of the components that we put out for the repetitive lab test restrictions that I mentioned as kind of one of our early projects. Another example where we're delving into send-out testing, which is, another big issue. It's not that, McLaren doesn't care about, all those daily CBCs and all those daily BMPs, but they really care about a $3,000 test that's leaving the system that may not have been indicated. So our early foray into what we call send-out or reference lab testing was inpatient thrombophilia. Again, same sort of a communication process after it had been vetted out, an infographic, a landing page, et cetera. And then this was one of that have been several pop-up opportunities to bring together the antimicrobial stewardship efforts under the high-value care umbrella. This one had to do with overtreating, overdiagnosis, and overtreatment of asymptomatic bacteria. So again, all of these will be in your slide set, but we think this is just another, I think, useful tool in the tool set of making this a scalable, sustainable sort of a process. So progress to date. So the program officially launched in late May, early June of 2018. Our early project was this focus on repetitive testing. And what we saw at the individual hospitals is similar to what a lot of the published literature is that if you looked at an individual analyte like a CBC or a TSH or a lipid panel, you could show that reduction in that individual analyte through, remember, the communication component, the audit feedback component, as well as a hardwiring component. You could see those go down. And that's all important. But what I think is more important, at least I would tell you the system administrators say, is what's the net effect. So when we rolled that up and we looked at the collective effort, looking at particularly high frequency, low value testing, repetitive testing on the inpatient side, what we've seen across the entire system is a 5% reduction. In fact, I just saw the numbers today. We're down to a 5.6% reduction across the entire system in terms of laboratory testing. Again, that doesn't sound very impressive, and maybe it isn't, but as I say, 5% of a large number is a large number. What that means is somewhere between 130 to 140,000 less inpatient tests are being done across the system, which benefits a variety of factors. One is we're not paying for the laboratory test and the laboratory reagent. We're not bothering the patient, hopefully, with phlebotomy for an unnecessary testing, and we have less chance of those false positives. But if you get enough tests, you're going to find at least some of those tests that fall out of whack, and then we sort of chase our tail with those false positives. So a 5%, actually we're now to a 5.6% reduction, looking at maybe a $9 or so sort of blended cost of a laboratory test. This is a saving north of $1 million. And again, it's through reducing unnecessary testing that was not benefiting the patient to begin with. And in terms of blood utilization, again, McLaren has a really, I think, a world-class blood utilization program. I'm saying that because I helped set it up. But in the last year, prior to re-engaging under high-value care, many of the hospitals had lost some of their focus, and we're seeing a rise in blood utilization. We saw by, again, reconstituting the blood management program under the high-value care program, we've seen a 7% reduction in red cell utilization from an already pretty lean organization. I think it was about a 6% reduction in platelet utilization, and total units saved is north of about 1,400 units in the last year or so. That translates at a very conservative about $1,100 per unit, looking at the cost of administering and buying blood products. Again, here's another $1.3, $1.4 million, which I think helps to drive and sustain the program as well. So with that, I'm going to take a breath and stop. Once again, I appreciate the opportunity to talk to all of you today. And again, at least it's one potential view of how we can consolidate many of the efforts under choosing wisely, under reducing waste. And I think importantly, even with relatively early data here, I think we're seeing a scalable sort of a process that can take on more than one issue, not just blood, but blood, lab, imaging, antibiotic stewardship, and again, I think palliative care is just around the corner. So with that, I'm happy to take any questions that anyone has.
Terrific. Well, thanks, Tim. This is Lisa Letourneau again, and some great insights and clearly some great systems level thinking. So really appreciate your work and sharing that with us today. We do have several callers on the phone, so I wanted to encourage people to jump in with any questions. You can just join right in and speak your question, or you can also use the chat box if you would like to do that. So, anybody want to jump in? I might have heard one there, but perhaps while people maybe are formulating questions, I'll jump in with one, Tim. Given the incredible, timing of the JAMA article and some of the accompanying editorials that point to, the reluctance really of the provider community for the most part to really seriously address, whether we position it as pursuing high value care or decreasing low value care. And a lot of concerns voiced in those articles about difficulty disrupting the status quo, and somebody's wasting somebody else's paycheck, and political forces.
Right.
What are your thoughts about that, and how? I mean, I love your framework of physician leadership and physician-led governance. But either if you want to speak to how have you managed to advance that in your system, which I'm guessing still relies heavily on fee-for-service. How is it different there, and what advice might you give to others who are largely stuck in fee-for-service systems?
Well, for sure, I think McLaren is sort of an index case. It is a, for lack of a better term, it's a federated system, right? So all these hospitals didn't grow up and say, hey, from day one, we want to be a system, right? This is a system that's been built over time, and that causes, political, issues to be able to do that. Information systems, I talked about hardwiring. This is the worst case scenario because they decided to go with Cerner. At this point, all 10 hospitals were supposed to be up on Cerner. Right now, one hospital is struggling to get up on Cerner. So we're going through a upgrade with Cerner, and then we have Meditech, what are the other ones? Paragon, an old version of Cerner. So it's kind of a worst case scenario, right? Politically as well as IT infrastructure. But what I believe in, and what we really are sort of doing here, is a top-down, bottom-up. So not only did we have to have conversations with physician leaders about this is the right thing to do, right? It's what we all need to do. It's what this is what we're supposed to be doing. We're supposed to be good stewards. We had to have the conversations with the administrators, because the administrators ultimately pick up the check for these activities. So for the administrators, again, when you talk to boards, they nod their head and go, yeah, I get it, we need to do it. However, right, we have a lot of laboratories, we have a lot of imaging. So the way we got through it, one is, again, communication, but I think also smart in terms of choosing our early projects. So where we're focusing primarily today is on the inpatient side. So on the inpatient side, as I think everybody knows, you get one price. So that hip replacement or that heart surgery or that knee, you get one price for it. So not only do clinicians but administrators get, oh, okay, so if we reduce unnecessary imaging or laboratory testing or blood products on the inpatient side, that's a good thing, right? Because the patient wasn't going to benefit from it, we're going to consume resources, and we don't get paid for that. So that was one part of kind of getting momentum and moving forward, was starting on the inpatient side where everybody's aligned, more or less. The second place where we've really delved into on the outpatient side is with the ACO, right? So with the ACO and with the employed physicians, they are incented through a variety of both federal as well as Blue Cross Blue Shield initiatives to look at, again, waste as well. So again, working with them is sort of the next level is what we're doing. So to answer your question, are there concerns? Have there been concerns expressed, especially by administrators more than clinicians? Are we, biting the hand that feeds us, so to speak? And the answer is yes, but we've had them transparently. I think there is an acknowledgement that we're all going in this direction, right? So we need to start moving in that way. And actually we had a summit for the program in April, and the CEO, Phil Incarnati, kicked it off, and this was all of the teams from across the system, and really said this is consistent with the vision that they created for McLaren when it was stood up, 10 plus years ago, it is providing value. And I think McLaren is starting to see this as a positioning for the hospital strategically, right? That they are a value-based organization and they're doing things right. In fact, their motto, which they came up with sort of concurrent with the high value care program, is doing what's best. And so, again, great question, Lisa. It's always part of the conversation, but we think choosing our battles, being transparent, and talking about the elephant in the room, but also seeing over time with these successes, even the administrators and the boards getting it and supporting it, I think is going to be the key, not just to our current success, but in the future.
Great. Well, thank you. Others, let me come back to the group.
And there's one in the chat, Lisa?
Yes, just seeing that. Thanks. So from Robert Pierce, curious as to whether the inpatient repetitive testing work involves soft stops or hard stops.
Yeah, a great question, and I'll reiterate it. Beginning with the end in mind, when we looked at this, we knew the only way to scale this thing, for lab imaging, et cetera, is hard stops. We can't go back and re-educate every single day, every single month. So that's why we put so much emphasis into the governance structure, the education, et cetera. So wherever possible for the laboratory, we do put in the hard stops. As I mentioned, we have that traceability and trackability. It says this is how we came up with the decision, this is who came up with the decision, et cetera. The problem, however, is that the only place that it is technically hard stopped is in the one hospital that has gone live or is going live with Cerner. For the others, we're having to do a variety of workarounds through the laboratory information system and through some relatively archaic systems like the Paragon system. So we think when we actually get no kidding functional scalable hard stops, we're kind of doing hard stop lights. We have the permission to do that we'll see an acceleration beyond 5 or 6% that we're at right now.
Super, thank you. Related to that, I would just ask a follow-on question of, have you got much pushback from the provider community around this? And I know you're trying to address this with your governance and leadership, but not everyone's involved in that. So what's the reception been?
Oh, doctors love change. I mean, you know that.
Yeah, yeah.
No, but again, I did this for years in my own hospital and then, at other hospitals with blood. I mean, you're not the boss of me, right? I mean, that's the bottom line. Is physicians don't like it. In fact, we did a lot of education across the system, the why before the how before we even rolled this out. And I remember one doctor standing up at, one of the sort of town halls or med staff meetings and said, you sound just like the insurance companies. And I thought, well, that's a new one. I've been called a lot of things, but I've never been called just like an insurance company. And I think my response was something like, insurance companies are not all good, but they're not all bad, that there are things that they're doing. In fact, Medicare, through the PAMA regulations and through the appropriate use criteria, is now doing pre-authorization. So we do get that pushback. We understand that there's always that 15% of physicians, of any group that adopts a little bit slower that are going to push back. But we really do feel the visibility, the traceability, the trackability, the repetition, really the scripting that we do starts to really break that down. And so what I will tell you, we are getting less and less resistance over time as we turn the crank again and again and again. It just becomes the way we sort of operate. But we certainly anticipated it. We can't get rid of all objections, but what our goal is to get rid of at least reasonable objections, if that makes sense. And that's through, again, choosing the projects, vetting out these particular projects, being very transparent in what we do. And frankly, I mean, we could spend the next 20 years just going through the Choosing Wisely list. And by the way, the Choosing Wisely list often comes up as sort of demo projects.
Great. Others? Any other questions here. Others who want to speak your questions.
One of the things that I did in this slide set, I was just going to say, Lisa, is I think I have my email, if not certainly through the Choosing Wisely network or through Kelly or Kate. I'm happy to converse by email or phone by anyone about any of these questions. Again, it's a lot to cover in a short period of time. So again, more than happy to share, as I would say, bumps, bruises. I can tell you stuff that doesn't work as well as the stuff that does work.
Great, thank you. I don't know if there is one more slide. Oh, there it is. Super. Thank you, Kelly. So contact info is right there. I was just going to ask again about timing, to talk a little bit about timing. So, a lot of this is culture change. Clearly, culture change takes a long time. But even the process of, setting up the governance and some of the systems, I think I heard you say maybe this has been in place for a year and a half, but can you just speak a little bit more to that about
yeah, so we spent about 5 months setting up the infrastructure at the system and at the site level. There was a lot of education and all politics are local, so you can't just sit at corporate and go, hey, you guys, we need to do this. So it was going to the individual hospitals, meeting with physician leaders, nursing leaders, executive teams, et cetera. So there was a lot of pre-selling of this as well. Program kicked off with all 10 of the hospitals having to have a up and running high value care team late May, early June of 2017. So basically kind of June was the kickoff for that. And so I'm actually, even in retrospect, fairly impressed between June of 2017 and to now, how many different projects that we've been able to undertake, and we're actually accelerating the number of projects that we're doing. So again, fairly quickly, actually, in terms of the usual glacial pace in terms of being able to execute and implement.
Yeah, absolutely. I would say that's rocket speed.
And I'll also add one more thing, just Lisa, is that, you mentioned, are there, were individual physicians not happy about this? That's true. Again, I hope I'm not speaking out of turn, but not you've got 10 hospitals, not all 10 hospitals are going, wow, this is awesome. Oh, another committee, more work to do, more metrics, more stuff to do. So just like, individuals move at varying rates, those 10 hospitals moved at varying rates. And we're very, very pleased that over time, some of the hospitals and hospital leaders that seem more recalcitrant and a little bit more skeptical, and understandably so, have become firm believers, and I think some of our evangelists. And what I've seen for years is sometimes it's those converts that start out being a little bit more skeptical and a little bit more vocal about the process, that once they see the benefit themselves, can become some of your biggest cheerleaders. And I would absolutely say some of the hospitals that I probably had more concerns on day number one are the ones that are leading the charge now.
Yeah, great. This is Robert. Terrific. And my frequent question in hearing great talks and examples like this, advice for those just getting started. I don't know. I think probably most of the folks on the phone are doing something, but in thinking of moving to sort of a more systematic approach like this within an institution, getting started?
Yeah, and you really, it's a top-down, bottom-up. I tried for years and years, driving change one-on-one. So I'm an anesthesiologist. So over the ether screen every single day, 5 different surgeons, 5 conversations. Hey, you really need that blood. Could you do this or that or the other thing? It's frustrating and ineffective. And so ultimately, getting started means building that coalition that includes key clinical as well as business leaders to really understand the issue, to figure out their what's in it for me proposition, and then start to bring the resources forward. And that's why I started with, although it seems redundant because you all know why we're here, those articles, that JAMA article, New York Times article, there was a Modern Healthcare article in June that was in the slide set, the IHI, these are all things to take to your executive team, to your clinical leaders, both physician and nursing leaders. I think that's where you start. You have to start at the top to get that understanding and that buy-in to really make this effective. Because if you don't have that air cover, that high-level support, any of these coordinating activities are not going to happen. But by the same token, you can't drive it from the system level. It ultimately has to be owned, and it has to bottom up. And so what we've seen is, although our first couple of projects came down from the system, right, we're going to start with the low-hanging fruit. What we now see is it's these individual hospitals that say, hey, this is a project that we think is worthy of pulling under this particular umbrella. So it does become self-propagating.
Great. All right. Well, we are getting close to the end of the hour. Any other questions from the group? If not, I'll turn it back to Kelly to wrap us up. And thanks
thank
again,
you, Lisa. Yeah, and thank you, Dr. Hannon. That was a terrific presentation. Really aligns with the heart of choosing wisely. And we appreciate your coming out today. And I want to say to the participants today that we learned about the work that Dr. Hannon was doing with McClellan through Workplace. So if you're doing something really cool that you would like the Learning Network to know about, I encourage you to post something on Workplace or send either me or Kate an email, because we'd love to highlight the wonderful work you're doing and learn from you. I will say thank you for joining us today. Thank you again to Dr. Hannon and to our wonderful Dr. Letourneau for moderating. And if you would like a copy of these slides and you're not on Workplace, please email either me or Kate. If you would like to join the Choosing Wisely Learning Network and you just happened onto this webinar, you can also email Kate. And we'll be happy to get you on. So thank you for joining us for October, and we look forward to talking to you all in November. Have a great day.
Thanks so much.
Thank you all. Thank you. Bye-bye.